Hi everybody, today I'm going to give a quick overview of the triad of death in trauma. So firstly we have coagulopathy, then acidosis and hypothermia, which together increases the risk of death or serious injury to the patient. Okay, let's start by talking about the hypothermic patient. Those patients who have had a prolonged extrication time or who have been entrapped in vehicles, patients who have consumed drugs and or alcohol, and those patients who have a traumatic brain injury as the damaged hypothalamus prevents them from regulating their temperature well autonomously. Patients at the extremities of age, so both very old and very young, have poor autonomous thermoregulation, as do patients who have sustained severe burns. During the burn injury process, these patients have lost skin and the underlying structures, including their sweat glands, which play a significant role in thermoregulation. Patients who have diabetes are also at risk of hypothermia as they have diabetic neuropathy and have a poor temperature regulation. So do patients with thyroid conditions such as hypothyroidism. Their metabolism is disturbed by their disease process and they will become more hypothermic more quickly. A recent study from the US examining hypothermic trauma patients found that the mortality rate for patients arriving to the ED with a core temperature less than 32 degrees was Hypothermic effects on the cardiovascular system include decreased cardiac output with a decrease in the response to catecholamines, including adrenaline. There is also impaired oxygen delivery to tissues as a result of vasoconstriction. And finally, irritable myocardial fibres can lead to arrhythmias, including AF and VF. So how does hypothermia affect bleeding? Firstly, we have impaired functioning of platelets. Then clotting factors and enzymes are inhibited, before finally inappropriate activation of clot breakdown processes. So now we know the dangers of hypothermia. What can we do about it? The first step is to ensure that any IV therapy that you give your patient is warmed. Secondly is to limit any patient exposure time. So ensuring that you do a good patient assessment, but using warm blankets and space blankets to make sure that they're covered as much as possible. So we want to ensure that we've removed any wet or soiled clothing from the patient and use available equipment, including bear huggers and blanket warmers, to raise that patient's temperature by about 1 degree per hour. If your patient begins to shiver, they have a 400% increase in the oxygen requirements at a cellular level. Okay, let's now move on to have a look at coagulopathy. Just a quick review, we have coagulation occurring when blood turns from liquid to a gel, which forms a clot. This happens in 3 steps, with vasoconstriction, the temporary platelet plug, and then formation of a fibrin clot. We have 12 factors, intrinsic, extrinsic, and common, which work together in our coagulation profile. 25% of patients who have suffered a traumatic injury will arrive to hospital already coagulopathic. Hypothermia exacerbates coagulation as factors are highly sensitive to temperature changes, and as the patient continues to hemorrhage, more platelets and factors are lost. Finally, coagulation is very pH dependent. A pH fall of just 0.4 can decrease coagulation by up to 70%. Dilutional coagulopathy occurs when a patient is hemorrhaging and is resuscitated using normal saline or packed red blood cells, which lack platelets and the clotting factors of whole blood. This further dilutes the remaining factors in the patient before the abnormal clotting cascade is activated with formation and breakdown of clots. So who's at most risk of coagulopathy? Patients taking anticoagulant medications, which may be for cardiac conditions including atrial fibrillation or post-stroke, as well as those patients who have genetic dispositions including haemophilia or factor 7 deficiency. So what do we do about coagulopathy? First and foremost, we need to stop the bleeding. So that can involve using simple techniques such as a tourniquet placed proximal to the injury, the application of a pelvic binder, or the application of a splint in the case of femoral fractures to reduce the blood loss. Treatment for coagulopathy should also include the administration of tranexamic acid and blood products including packed red blood cells, fresh frozen plasma and platelets. Finally, let's take a look at acidosis. So just for another quick refresher, pH is related to the number of hydrogen ions that are in the blood, and this is controlled by both the pulmonary and the renal systems. A patient may be considered acidotic when their pH falls below 7.35, which basically means that there is an inadequate supply of oxygen to the tissues. The demand is high, but the supply is low. In the trauma patient, this high demand but low supply of oxygen can be for a number of reasons. Firstly, if we look at hemorrhage, the sheer loss of red blood cells can lead the patient to be anemic and therefore has inadequate transport to allow the red blood cells to carry the oxygen to the tissues. At this point, we start to see the interconnectedness of the elements of the triad. Being hypothermic, the patient will experience vasoconstriction, and that in turn decreases the ability of the vessels to transport oxygen, thus worsening the acidosis. With the ongoing mismatch between the supply and demand of oxygen, metabolism moves from the usual aerobic to the anaerobic mechanism, with lactic acid being one of the byproducts. As the perfusion decreases, lactic acid continues to accumulate in the tissues, and this buildup of lactic acid actually lowers the pH even further. It's important to note that this acidotic process can be occurring even in the context of normal or near normal vital signs. It's important to understand the role of IV therapy in trauma as well, with our two most commonly used fluids being normal saline and compound sodium lactate having low pHs of 5.5 and 6.5 respectively. These fluids have the ability to worsen a patient's already occurring acidosis. Things that will worsen a respiratory acidosis for a patient include a head injury and alcohol. Both of these decrease the respiratory rate and thus increase acidosis. COPD in a patient may mean that they are a retainer, and also a flailed chest will be a mechanism for poor respiratory effort. So just to review, hypothermia, coagulopathy and acidosis form the triad of death in trauma, a set of 3 physiological abnormalities which when combined significantly increase the risk of death to a patient.